Thank you very much for having me here today. You're a large crowd, and I normally like to have an interactive talk as much as possible, so it's going to have to be interacting by hands, I think. But if I speak too fast or are using acronyms, particularly UK-based acronyms, please put your hand out and go like this, so that I can stop, slow down, or explain. I thought that was a fantastic introduction, very hard act to follow. I just want to check, I'm talking to you, how many people here are frontline clinicians working directly with children and families? The very vast majority. How many are researchers? Of course, you can be that and a clinician. Okay, about 10, 15. How many are managers, managing services? Okay, about 20, 30. How many are commissioners, funders? 1. Okay, focused on you. How many here are administrators, supporters of services? About 10, 15. Who have I forgotten? No one's putting their hands up for the moment. Okay. So what I'm planning to talk to you about today is about the whole issue of outcome measurement and in particular how we can involve service users, children and families in their own treatment and planning. And the model that I've increasingly come to see this being part of is shared decision making. And that's an increasingly sort of driven approach across all of healthcare, not just across child mental health. What I'm going to do today is talk to you briefly about the context that I'm coming from, and in particular about 3 projects. The CAMS Outcomes Research Consortium, which is a collaboration of child mental health providers committed to developing the best ways of evaluating outcomes in our work. Children and Young People's Improving Access to Psychological Therapies, which is a government initiative in the UK, which I think Peter Fonagy may have mentioned yesterday. But I'm going to talk today about its approach to outcome measurement and young people's participation. And then the final project I'm going to draw on today is shared decision-making in CAMS, which I and other colleagues are involved in, which is a project working with a number of services across Britain who are trying out different models of how to really make children be in the way those young people were saying, be part of the process of their therapy, be making decisions that are right for them. I'm going to give it a couple of brief definitions about what I mean by outcome measurement and child and family involvement. And then I'm going to spend most of the talk going through those 5 steps. Oh, I seem to remember you had a pointer. Can I possibly borrow it for later? The 5 steps of shared decision-making and going through in detail the approach we're using in those projects to do outcome evaluation and to include young people. Can I just check, though, again, thank you very much, before I start, how many of you currently are doing outcome measurement as part of your routine clinical work? Probably about 20. And keep your hands up, those who are doing it. How many of you think this is a really worthwhile activity? Keep your hands up. Oh, there's more than they're doing it. That's great. And how many are a bit dubious and think it's just another bureaucratic thing that means lots of form filling? Great. I'm 1. I suspect you're not alone, but I may be preaching to the converted. That's great. In terms of the outcome measurements, how many are doing clinician-rated measurements? About 15. How many are doing patient-rated measurements? About 10, 12, 15 maybe. How many are doing it from the point of view of the child? About 10. How many from the point of view of the parents? About 15. Fantastic. Thank you. So, let me introduce you to how many people have heard of CORC, the CAMS Outcomes Research Consortium? Okay, a select minority. We're a some of you may be members without knowing it. As you can see, we are a collaboration of child mental health service providers. It's a grassroots organization, grew bottom up. Years ago, when I was working in clinical practice, by background I'm a clinical psychologist, I and other colleagues became very interested in thinking about how do we know if we're actually helping the young people and families we're working with. So we started to experiment with different ways of evaluating outcomes. Others got interested in what we were doing, and we formed a learning collaboration which involves service providers, managers and commissioners to think about the best ways of doing that. That opened to wider membership in 2004, and since then we've grown to be about half of all the services across the UK and also members here in Sweden, which we're very delighted about. And how we work is that people use a common set of outcome measures, which include those based from the point of view of the young people, from the point of view of their parents, and from the point of view of clinicians. And every year, those information from those measures are sent to the small central team that you can see on your... That's us, outside the Anna Freud Centre. Data are sent to us, and we produce a report that shows data at the service level. So we compare service outcomes with those for all the other services in the collaboration, and we are increasingly trying to refine our statistical analysis to be able to say, is there a significant difference between your service and other services on different areas of outcome? I'm not going to talk about that level of analysis today, but if people want to ask me questions about that, I'm very happy to answer them. And if you want to go and see our website, you can learn more about that. Slower. Thank you. So these are people I'd like to acknowledge who are part of CAM's Outcomes Research Consortium. That's our committee of people that run it. On behalf of all the services, we have research advisors, and we have particularly collaborators from Sweden, as I mentioned. In terms of the second project I wanted to talk with you about today, it's the Child IAP project. And for this project, it's a government initiative to try and what they call transform services across England. And they're trying to do that in a number of ways. One way is by training practitioners in more evidence-based treatments. So in this first year, that involves training people in cognitive behavior therapy and parent training for anxiety and depression. But the aspect of it that I want to draw on today when I'm talking with you is that the other element of service transformation is based on intensive routine outcome monitoring. So I and colleagues have been involved in developing guidelines about how people might institute routine outcome measurement, drawing on our learning from Cork, but also drawing on learning and research from internationally, including work by John Weiss and others. And there's a large group of people that have been involved with me in developing some of these ideas. And I need to warn you that there are people in England who would see me and what we're doing as the devil incarnate, because it's about more forms to fill in, what's the point? What I would say is that there are also increasing numbers that feel there may be something in this if we can get it right, if we can make it meaningful for clinicians and for practitioners and for children and families. And there are debates between us about how to get that right, but I think we're all absolutely clear that unless we have measures that are meaningful to clinicians and to children and families and that can help us in our actual work with that child and that family, we should not be using them unless we have ethical permission for a research study. So I suppose increasingly I've come to the position that if you as a clinician are being asked to fill in a routine outcome measure and you don't know why and you don't know how it helps that child and family, you should not be doing it. You should only do it if you feel ethically that helps that child and family. The only other situation in which you might fill in a measure is if you say to the family, we're doing this for research, I'm not going to look at the outcomes, it's not for you, you have to have informed consent to fill in this measure. So I think we need to be very clear about that. Therefore, as part of this initiative, I and colleagues, and this is a group led by my colleague Duncan Law, have been developing guidelines for practitioners about how to use the outcome measures we're suggesting in a meaningful way. And all these documents I'm talking about today are available free on the web. The website details I put on the slides, and I'll make the slides available. And you're very welcome to have a look at them, comment on them. We will be reviewing the whole approach in July. It only went live in January, so we're very interested in any comments people might have. Again, large numbers of people came together and very selflessly gave their time. These are busy clinicians, most of whom weren't paid for their time, who came together to think about how can we do this in a meaningful way. And one of the things we want to be very clear about is some do's and don'ts of when to use measurement tools and when not. Now, you may think that things like item 3, do look at the answers when people have filled them in, would be fairly self-evident. But having been part of and leading Cork for many years now, I can't tell you how disheartening it is sometimes to go around the UK and find people saying, our managers tell us we have to use the SDQ. How many people have heard of the SDQ? Fine, good. Our managers tell us they have to use the SDQ because we're members of Cork. We can't see the point. Children and families fill them in and we never look at them. It's just not okay. If you really believe it's not the right measure, don't use it. It's absolutely not okay for children and families to be filling in measures and then no one looking at them. At the very least, look at what they've said in terms of the length of problem or the impact on their lives. The final project that I'm going to be drawing when I'm talking to you today is around shared decision-making in child mental health services. This is a project that's funded by the Health Foundation, which is a national charity in the UK that supports innovative work across healthcare. And we put in for a competitive bid to develop shared decision-making in CAMS, and we're one of 8 bids that were funded across healthcare, all trying to transform the relationship between those using healthcare and those providing healthcare. As part of this project, we're working with 4 clinical teams across the UK. Those teams are all trying out different ways of involving young people more meaningfully in decisions about their care. And most of the teams are outpatient teams, but this team's particularly interesting because they're a forensic inpatient team. They're working with some of the most troubled young people, and the issue of what choices you can give someone who is possibly handcuffed when you're speaking to them and is not allowed to leave are particular issues for that team. Thinking about how can we have shared decision-making, how can we be open with young people about what options there are and what options there aren't. And to be very clear, shared decision-making does not mean simply saying, over to you, young person, over to you, family, you choose. It is absolutely about saying, this is my belief, this is what I'm saying as a clinician I can do, this is what I see as being the things that are right for you, we're going to discuss this together, and everyone has to come to some agreement as to the ways forward. That group is overseen by a steering group that is half of professionals and half of people with expertise in service use. So we have 2 young people who are current service users and 2 participation workers who work with them to support them in their work as part of the steering group. This is certainly the first time for me that I've worked directly running a project in which young people are co-running it with us. And I have to say I was nervous to start with, and it's been an absolute fantastic experience, and they've brought a huge amount and really challenged us at different points about our ideas and our thinking and helped develop our materials and ideas. So moving to definitions then, I guess the first issue really is thinking about outcome measurement and who is it for. And I suppose insofar as I've learned anything about outcome measurement over the last so many years, it would be that the fact that people get confused between which level one's measuring for is probably the biggest problem in outcome measurement. That and people wanting to have the perfect measure. Those are the two major challenges, I would say, for us. In terms of who's it for, I'm going to talk mainly today about outcome measurement that's for the individual client that you are working with at that moment. But I think it's also important to be thinking about outcome measurement for the practitioner, for us as clinicians, to think about how would I know if I'm doing better or worse than someone else? How would I know if I could be a better clinician? So I'd be interested again with a show of hands. How many here today would be able to say they know how good they are with working with a particular client group as compared to colleagues? We are working in the dark. And I think that's a problem. Now, that is not to say we want league tables and we want to say, you know, we want to encourage a very unhelpful competition. But I do think it's a rare area of work where it's difficult for us to have feedback. How would we know? How would we know? How would you know if you could be doing something different? How would we know if we weren't going as fast as someone else? How would we know if we could learn from someone else? I suppose those are the questions that very much preoccupy me. in terms of service managers, how would they know, how would you as a service manager know how best to help train or support your work staff, or how your service is doing comparable to other services, or whether there are things other services could teach you? Again, for funders, how do funders know what's the best place to put money and where would it be most effectively placed? Policymakers also need this information. But what I would say is, and what my key learning, if you take nothing else from today, one thing to learn from today, is that I think very different measures are good for these sort of answers than are good for these sort of answers. And I think that's one of our big challenges. So for the individual client in front of you, to understand what's meaningful in terms of outcomes for them, we need bespoke measures that are about the uniqueness of that individual. We know from interviews and from research that Pippa Moran and others have done with young people that their concerns about outcome measurement are very similar to those from clinicians. They don't want to be reduced to a tick box. They don't want to be reduced to a number. They're worried that measures do not capture the full complexity of the clinical reality. They're worried that they'll be used as ways to say to people, you're better now, go away. They're worried there'll be yet ways to cut funding. So the sort of concerns that clinicians have are very much mirrored by young people. And what clinicians often say to me is they want measures that are unique to the young people they work with. It's very rare when I go around in the UK, it may be different here, that I meet a group of clinicians that don't tell me that the young people they work with are different here and harder to work with than anywhere else in the country. And so the measures for those young people have to be really different. And it's true in that everyone is different. And I think what makes people good clinicians is that attention to uniqueness, that attention to detail. But that's also what makes us poor evaluators. Because we're so concerned with the uniqueness, we're very resistant to any generalization, any aggregating up. And I think, again, what I've come to believe, and these are very personal beliefs, not all colleagues would share them, is that sometimes what makes people good clinicians, or what draws people into clinical work, is that they love the creativity of it, they love the interaction, the personal interaction. Not always, often, they tend not to be numbers people. They tend not to be turned on by graphs, statistics, or numbers. So when they're presented with information from outcome measures, there's a sort of blank look and, well, I don't know what to do with that. And I think that's a real issue for us. Until we learn about measures, until we learn to love measures and treat measures with the uniqueness that we treat our clients, we're never going to get outcome measurement as part of participative work. And I guess that's one of the challenges for us going forward. In terms of involvement of children, young people, and families, again, I'm going to focus particularly today on shaping individual case choices and looking at the individual client journey. But there's also the possibility of informing service development. We know in the UK, increasingly young people are being used as part of recruitment panels. When a clinician is being recruited, young people with experience of service use are now part of the recruitment panel to check whether that person actually is able to talk with young people, to ask sort of questions that young people want answered, to audit services, and even to run services. There are increasing numbers of peer-led groups within the UK. So again, I think these are all very interesting models of participation. But again, I would say that as with outcome measurement, don't confuse the different levels. If you're doing this, you can have all the fantastic participation at this level you like. But if you're not actually working with individual clients that you're working with in a participative manner, then you're not doing participation. And it's very different skills needed. So what I'm going to spend the rest of the time doing is going through what I see as being the 5 steps in shared decision making. And can I just check, am I now going at the right speed, or people like a bit slower? Slower. Okay, keep reminding me, go like this. I have to tell you, in the UK, people say I speak too fast, so. Okay, there are 5 steps in shared decision making. The first step is agreeing problems and goals. Don't worry, I'll speed up. The second step is agreeing what options, understanding what options are available. The third step is agreeing what options to try. The fourth step is then reviewing progress, exactly as that young man said in the video earlier. And the fifth step is making changes as necessary. And we're going to go through each of those steps with you. I'm also going to cheat a little and make the first step into 2 parts, looking at key problems and looking at goals. And in doing this, I'm going to be drawing on the learning from Cork, from the Child IAP project, and from shared decision making. So, in terms of agreeing key problems, there's also no clear way of doing an assessment that's shared across the whole community. And what I would say is that whatever ways you use to do an assessment, it can be questionnaires, it can be interviews, it can be observation, the issue is that you as a clinician come to some decision, come to some formulation of what is the problem here and what you're trying to work on. And I think, again, it may seem self-evident, but certainly in the UK, sometimes we struggle with this. On a research project that I was involved in recently on a different topic, we had a very bright researcher going through hundreds of case records. She was actually looking to see about how many times the liaison between health and education was mentioned. These were from very good services that were part of this research project. She came back after 2 weeks of looking at these records, saying not only could she not work out if there was liaison between schools and health, she couldn't work out what the problem was, what was being worked on, how they would know if they were doing any better, and yet there were reams of notes. Notes that said, Dad said this, Mum said that, boy said this. I don't know whether that happens here, but there's certainly an issue. Does it happen here? It's a real problem. So my challenge back to you, and I can't remember whether I said this a couple of years ago, because I know at some point someone's going to say to me when I come to the outcome measures, there's no time. There's no time to do outcome measures. I'd like to ask you how much time you're spending writing notes that no one's ever going to read again. So it's one challenge. I want to be provocative here to get people thinking. Also, how much time is spent discussing cases that you never see. These are two things that I want to sort of challenge back to you when you say there's no time, because you will say it to me. So I'm now going to go through some of the measures that we're using, and again to stress that I'm going to talk a lot about questionnaires as we go on. If there was a different way of doing this that didn't involve questionnaires, I would go for it. I'm not a fan of questionnaires, and I'm not a fan of filling in pieces of paper, and neither are young people. Some of these we need to think of as clinical tools that can be woven into conversations. Some of them can be given out a piece of paper, but I think part of our learning is thinking about how we use these as tools. Think about these as part of your clinical armory, just as you have the magic questions we ask as part of family therapy, or the sort of thought modeling that we use as part of cognitive behavior therapy, or the sort of interpretation of the transference that we use as part of psychodynamic. These should be clinical tools that we should spend as much time understanding, knowing their flaws, knowing their limitations, challenging, as anything else. So the SDQ I know that you're all very aware of. What we're also using in Child IAPT is something called the Revised Child and Depression Checklist, developed by Bruce Chaprita in the States. And all the questionnaires I'm going to show you today are all freely available. This is not in Swedish, although it is in Danish, but the SDQ is in Swedish, but they're all freely available to use and translate if you would like. The reason we've added in the ARCADs is because it's much more detailed on anxiety. What we've discovered, it's 47 items, and we use it at assessment. Clinicians were very worried about its length and thought people would not like it. We've been using it since January, so we've only got very tentative feedback so far. But feedback so far is extremely positive. What we're hearing is that young people say, it's the first time I've been able to say some of the things that have been making me anxious. Clinicians are picking up anxiety issues they hadn't appreciated, and it's giving them a chance to talk with children and families about things that are worrying them. What we are learning is that it depends on the child how you administer it. For some people, it's fine to give it before your first meeting and ask them to fill it in and bring it. For some people, it may take a whole meeting to go through together. I guess my plea would be, if you were going to a doctor and they took your blood pressure, and then they said, no one's ever trained me in how to take blood pressure or what to do with the results, I think you'd be shocked. But how many of us here have been trained in using any of these outcome measures? What, 2, 3, 4? Great. 5. I would hope if I was coming here again in 2 years or in the UK, it would be exactly the same in the UK, that would no longer be the case. If we're going to use these as clinical tools, we have to understand them as clinical tools. We have to treat them seriously. We have to know their strengths and their limitations. And I think that's one of the reasons why the work, I know Anna's going to be talking to you later this afternoon, one of the reasons why her work is so important on CGAS, Because until you really understand these measures, all the measures are flawed. All of them have got limitations. I can absolutely guarantee you that. Bring me any measure, and I will tell you the limitations. Thank you. Being reminded to slow down. I knew I'd speed up. So we need to introduce these with care and be clear with people about why we're using them. We need to make sure that we understand what they mean in terms of clinical cutoffs. So these pages that I'm showing you here are from the book that I showed you at the start on the Child IAPT website that show you all the clinical cutoffs for the different measures. So you can look, if you've got a child in front of you who's 16, who's just filled in the measure, it tells you how likely it is, given that score, that their problems are clinically significant in that area. Now, I want to be very clear. This is not saying they now have that diagnosis. This is one more bit of information. We all know there may be young people who say, I've got no problems, and your clinical judgment is not that. Or there may be young people that say, everything's terrible for me, and your clinical judgment is not that. Clinical judgment overrules any numbers. Just because it's a number doesn't mean that it has higher status than other information. But it is a source of information that is worth thinking about and worth being aware of. And it's also something that you may want to reflect on with children and families, particularly, as is often the case in our work, where there are differences in viewpoint between a child, their parents, and a clinician. We know from the work of John Weiss and others that it's actually rare to find agreement, that you had agreement. The rest of the time, there was no agreement on what the problems were, let alone their extent or what you were trying to work on. So I know that I'm talking to you about things that clinically you're dealing with every day. In terms then of categorizing the problems, this is a checklist of 23 problem definitions that we've come up with Child IAPT that are acceptable to UK clinicians, again for using as people see fit. And we've also developed a checklist. You can't read it very well on here, but you'll be able to get it if you go to the website, a list of complexity factors that we think may influence outcomes. So when we're aggregating outcomes at the national level and comparing across services, we can take into account those complexity factors that people tell us make a difference. So for example, do we expect similar outcomes for a young person who has, say, phobia or, say, depression, if they are looked after or have a history of being in care or have a history of abuse or if they have parents with significant mental health issues? All these are things that clinicians tell us are likely to affect and impact on outcomes. So we're trying to take those into account when we do the analysis at the service level. Again, because we're at the start of a journey of learning how to do sophisticated analyses where we compare like with like. The second part of the first step is agreeing key goals. How many people here agree goals as routine with young people they work with? Probably about a third. So there are a number of ways of doing this, and I suppose when I'm talking about goals here, I'm not necessarily talking about them as being specific or measurable or necessarily very clear-cut in the way that we might want them in cognitive behavior therapy, for example. We're talking more about something that could be used with any modality of work, where what you're agreeing is, what is it we are working on here? It could be framed very generally, like, I want to have less worries, I want to get on better with my mum. And there may be different goals for different people. But the issue is that we should be accountable as practitioners, that we can say, what is it we're trying to work on, and can we keep an eye on that going forward? So John Weiss talks about something called COWS. How many people have heard of COWS in this context? 2, 3. What it stands for is Crisis of the Week. And what it means is the experience, I don't know whether this is true of you, but it's certainly true in the UK, of families coming in and saying, oh, I don't want to work on that now because there's something's blown up in my life and there's all this other stuff going on. And it becomes very hard to focus on what it is you were trying to focus on. Now, that doesn't mean that you don't need to go to those other places and look at those other things and deal with crises as they come. But there can be a feeling of being blown around. And I think one of the issues in clinical work is to be as clear as one can about what am I trying to achieve here? How will I know when I've achieved it? And can we monitor progress? So one of the things we're suggesting people do is rate goals on a score of 0 to 10, where 10 is the goal's completely achieved or the problem's completely gone away, and 0 is we're nowhere towards achieving it, and 5 is about halfway. There are other methods of doing this. Have people come across this, the outcome rating scale? Some people here. This is an approach used by a group, Barry Duncan and Scott Miller, who have now gone separate ways, but both of whom use this approach. This is a visual analog scale whereby the child or the young person rates how they're feeling generally as an individual, interpersonally, socially, or overall. They simply put a cross on the scale, and then again you can monitor over time how things are going. In the UK, this is being used particularly by a group who call themselves OOCAMs, outcome-orientated CAMs, and they say that it's absolutely transforming their practice. They would also say that it needs to be embedded as part of our overall service transformation with a lot of other philosophical underpinnings, and I'd encourage you to look at the work on their website, even though they do spend quite a lot of time on their website saying why they don't like Cork. But I still think you should have a look at it. I think what they're doing is really, really interesting. This is a version that's for younger children as well. In terms then of agreeing, so once you've done the assessment, you've agreed your goals, the next step in shared decision making is thinking about what options are available to you. How many people have looked at this website? Good to hear it. About half. Great. This is a website that's been developed, as you know, in collaboration across, I thought we had our names, but I must have taken them out for some reason. Across the UK and Sweden. So Bengt and Ulla are working with us on overseeing this and developing it further. And one of the things we've been discussing, in fact, is given that you now have your evidence-based guidance, whether we can start to think about updating this in the light of what you've pulled together here. Our feedback from the UK is that people are using the website, but they also use, I thought I had a booklet, the booklet version, and they can use that sometimes to discuss with children and young people what the options are that are available to them. Again, to be very clear, this is not about giving out the booklet and saying, choose your option and we'll do it. Nor is it about saying, if it isn't in this book, we don't do it. Rather, it's about encouraging young people to challenge and ask questions and say, why are you suggesting what you're suggesting? So it may be you're suggesting doing something that's not in the book. That's fine. But you need to explain to the young people why. Why do you think this is a good idea? Why might other people think something differently? How will you know if it's not working? What options have they got to make decisions? I've yet to have evidence from anyone who's used it in the UK of a young person turning around and refusing treatment that someone has argued with them would be a good idea. So you may say, well, my experience of working on people is this way of working really helps. But it's good, what we're trying to do is empower young people to have those discussions, to be able to challenge and argue and discuss. An allied initiative that's going on across healthcare generally is done by a group of colleagues, Glyn Elwyn and Richard Thompson, in Cardiff and I think Richardson and Newcastle, where they've developed this Ask 3 Questions campaign. This is across all healthcare. This is not specific to mental health, nor indeed to child mental health. And what they're suggesting is this little card should go out to anyone before they see any doctor. And that people should be encouraged to ask these 3 questions. What are my options? What are the possible benefits and risks of those options? How likely are the benefits and risks of each option to occur? Now, it may be we want to adapt this slightly for child mental health, but it seems to me in there is the kernel of a good idea. And I think we need to be encouraging our young people and our families to raise questions with us about what is possible for them and what is right for them. One of the things they learned from this MAGIC project is that they put these up on notice boards in doctors' surgeries. But they say it only has an impact if it's actually in the consulting room. Waiting rooms are one thing. Messages given in waiting rooms may be all very facilitative and friendly and great. When you're seeing the person in the consulting room and you're in the doctor's space or the therapist's space, then the rules are different. And if we're going to change those rules and make these more participative conversations, we have to have this sort of information in our consulting rooms, on our lapels. I haven't yet worked out what the wording is to go on our lapels, but there is something there that we need to be wearing. Of course, the choices that we make are not just about treatment choices. It's not just about I'm choosing CBT or I'm choosing family therapy. There may be a whole range of choices that a young person should be involved in deciding about aspects of their treatment. How many people here discuss with young people how frequently they would like to meet? Fantastic, about 3/4. One of the things that the UCANS group were telling me they do is they will now very much discuss, even with high-risk cases, how often they want to meet. So one thing they were discussing, sharing with me was an example of a young woman who was self-harming. She said she wanted to meet every 3 months. The practitioner was very worried, but said they discussed the options, discussed the issues, and decided that, yes, this was right. And in fact, they said it was actually less risky because what was happening before was they were offering the appointments, they weren't turning up, they were then chasing, and actually handing over some control to the young person they felt helped. Now, everyone has to make their own choices about that. I'm not saying let the young person who's self-harming always decide. That's a decision for you. But I think if we really go down the route of shared decision-making, there are some interesting challenges as well as opportunities. Similarly, this issue here about diagnosis, I think, is an interesting one. How many people here discuss with young people what it means to have a diagnosis before they go ahead and decide whether they're going to make a diagnosis? Again, about 1/3. So again, an interesting area. In the UK, what we hear is that sometimes happens, but also what sometimes happens is young people are being assessed, for example, for autism, for Asperger's, for ADHD, and they don't know they're being assessed. Their parents have brought them. The parents know they're being assessed, but it's not discussed explicitly with the young person. So I think, again, thinking about the ethics of care and the ethics of what we're asking people and what they have rights to make choices about. Thank you. So having looked at the range of options, the next issue is deciding which options to try. And here I've come across recently shared decision-making aids. How many people here have used a decision-making aid? One. I have to be honest, I've never used one either. I've only just discovered them. And I'm not sure how useful they'll be. But I wanted to share them with you. When the MAGIC team, the one I just mentioned about the 3 questions, they had said they spent years developing decision aids for people in physical medicine and found no one used them. They then discovered these option grids, which are 1-page sheets saying what your options are and weighing up the pros and cons. And they say those are used a lot. So I wonder if one of the issues for us in child mental health is to think about options grids. But I just want to show you some examples of decision aids for ADHD, for example. So this is available on the web. The link is above, so when you have the slides, you can follow it if you want to. This is from Ottawa, and it's a decision aid for attention deficit disorder. And the thing about decision aids, what they're saying is to make informed decisions, it's not enough just to know the information. You also have to think about what your and the child and family's own values and preferences are in weighting the options. You have to be clear that they really understand the issues at play, and then they can make a decision. So using this decision aid, you both get the facts about ADHD, you then compare options, you then weight how important different factors are, you then make your decision, but you then quiz yourself to double check that in making that decision, you've drawn on all the relevant facts. So for example, this in effect is an option grid, thinking about, should my child take medication or should my child not take medication? And these are questions that the parent might want to have. One of the learning that Glyn Elwyn says from developing option grids across physical health is, it's absolutely crucial that you involve the people who are going to use these option grids in developing them. We as practitioners have all sorts of fantasies and beliefs about what sort of questions people are carrying with them into these decisions. Often when you actually talk with service users, they have a whole different set of questions. And it's really important that it's their questions that drive the options grid. but our expertise that can help think about what the answers are to those questions. In terms of thinking about feelings and preferences then, you need to think with the family, and this, you can do this actually online with the family, about what is most important to them. Is it really important to them if their child wants to take medication? How do they weight their preferences? And then, in terms of quizzing themselves, checking the facts, checking they understand if they're making a decision about something as important as medication, do they really know the pros and cons of the decision they're making? And here are some links if you want to try. Finally, I want to move on to the issue of measurement session by session. So how many people here measure progress every time they meet with a young person? 2. Do you find that helpful? Yeah. Converts, great. Those are your champions. This is the way that we're moving now in the UK. And I want to be open up front. There are 2 reasons for moving in this direction. One reason, which is the less good reason, I think, but is probably the bigger motivator, it's a way of getting data. If you do outcome measurement when you first see someone and 6 months later, which is what we've been trying for several years in CAMS as part of the court collaboration, you very rarely get that 6-month data. You very rarely get the follow-up. So you're looking at 20% of cases. And then it's very hard to know what to make of that because you don't know about the 80% that you don't have the data on. So one reason for doing it every time is then you have the information when they stop, when they drop out. You've always got the information from the last meeting of how things were, so you can at least make some assumption of how things were at that point. The better reason, and the more relevant for our discussions today, is because it helps you, informs your clinical practice in the here and now. What we know from research from Michael Lambert and John Weiss is that giving feedback to practitioners in the here and now from how things are going each time they meet actually leads to better outcomes. The first randomized control trial in child mental health has just been completed by Len Bickman, published this year. I would encourage you to look at the findings. It's really interesting. What they did was they randomly assigned child mental health professionals. Everyone did session-by-session outcome monitoring. Everyone got feedback, but some got feedback once every 3 months, and some got feedback every week. Those that got feedback every week had better outcomes. And the more they looked at the feedback, the better their outcomes. However, interestingly, only a third of the practitioners never looked at the feedback. So I think the big challenge here is, as practitioners, we've got to be interested. We've got to feel this is relevant for us if it's going to make sense. In terms of the model we're suggesting for Child IAPT, we're suggesting the way of doing that is threefold. I'm going to take you the three things. The first is to have idiographic measures, so to measure those goals that I talked about earlier every time, to help make sure we're focusing on the things that are actually most important to that child, to that family. Or to use the UCAMS or the outcomes-oriented approach. Either goals or this are fine. These are clinical tools to be used and to track progress. We have a free database that we make accessible to everyone. Anyone here is welcome to use it as well, which we call the CODE database, and that allows people to produce graphs if they want to, and to look at those with young people. We also suggest, however, using symptom-specific measures. And this is where we are increasingly developing our idea about saying those need to be as relevant as possible to the problems that the young person is bringing. We think where we have gone wrong in the past and why sometimes people feel so concerned about the SDQ being used as a measure of outcome is it's too general. It doesn't tell the clinician anything they didn't know. What we think is needed, and we also know that you're more likely to see change, and it's more likely to be sensitive change, if you're using a measure that's relevant to that specific problem. So what we've done for Child IAPT is we've developed for this first phase a set of 10 different short measures that people can draw from as relevant to the child and family. And again, in terms of participating working, we would encourage that to be an explicit conversation with the child and family to say, which of these measures makes most sense to you for us to use? Which of these items make sense? So this, for example, is the measure that you could use if someone was feeling very depressed or low. I feel sad or empty. I feel worthless. I cannot think clearly. These are sort of questions that would be helpful to be tracking over time to see if there's change. Or If you've got someone that's got separation anxiety or feeling very anxious or sad away from their parents or not going to school, would these be the sort of items that might make sense? Now, these are subcategories from the RCADs. They have norms, so we can also track how this young person is comparable to other young people, bearing in mind the norms are US-based at the moment. There are also other ones for OCD, for post-traumatic stress disorder, for panics, for post-traumatic stress disorder, and for out-of-control behavioral conduct disorder. If none of those measures feel right, then the suggestion is that people should use a very brief measure of impact on the child's life. At the very least, we should be monitoring what impact are these difficulties having on your life, and you'll recognize this as a sort of modification with Robert Goodman's agreement of the impact scale from the SDQ. So finally, what that involves then is checking in with people how things are going generally and making changes as necessary. What we've introduced in Child IAPT is the suggestion that towards the end of a meeting, people should review with the young person these 4 questions. Did you feel listened to? Did you talk about what you wanted to talk about? Did you understand the things said in the meeting? Did you feel the meeting gave you ideas for what to do? How many people currently review at the end of each meeting how people have experienced that meeting? About a quarter. Do you find that useful? Yeah. The feedback from this has been remarkably positive. The key thing here is this is not about a sort of customer audit. This is not about saying to the young person, how was I want a rating, it's for my personal use. This is about a conversation. It doesn't have to be put onto paper, it doesn't have to be given as a piece of paper, it can be part of a conversation. This is about checking in. Did you feel listened to? Did I understand what we were talking? Did you understand what was talked about? One of the things that's come out so far from people that have used this is we've had really experienced, really good clinicians saying they had a session, they thought it had gone really well, they'd really explained things clearly. They say to the young person, did you understand things? The young person says, well, sort of. And it actually gives an opportunity to go over again and say, well, which bit didn't you understand? Which bit can we go through in more detail? If there were things that we didn't talk about today, can we talk about them next time that are important to you? Clinicians say it actually helps them have the information, and you can use this again as a clinical tool, so it may not be asking all the questions every time. It may be asking different questions. But again, it's about communicating interest and genuine concern for feedback from the young people. There are different ways of presenting this. So some of the ways that our shared decision-making sites are trying it is also as a bullseye, where people can point the answer and say, yes, I felt listened to totally or not at all, depending on where they went, or as a thermometer. Again, with younger children, some of the sites are investigating also doing other things with balls, where people throw balls into the right bucket, whatever makes sense in terms of interacting with young people. Again, from the point of view of UCAMs, there's also the possibility of session rating scales that can be used, again, as a way of reflecting on how things have gone, again, for younger children. Where I think we're still very much at the early stages is knowing what to do with all this information, making sense of it. Our suggestion is that people should be reviewing the outcome information in supervision, between sessions, with families. But it takes time to work out what these things mean. It takes numbers of families till you get a sense of, you know, what does it mean if someone's off track? What does it mean if someone's not doing as well as we want? In UCAMs, and I think this is one of the most interesting things they're doing, what they do is if after 5 meetings, the person has shown no progress, that case is automatically brought back to the team for discussion. And a lot of the time, that case is then moved to someone else. Mutually agree with the clinician. It's not that it's taken away from the clinician, that it's not done in a punitive way. But we know from the work of Michael Lambert and others, that if you're not seeing change early on, less likely that you will see it over time. Now, this doesn't mean there aren't cases where we have to plug on. It doesn't mean that there aren't cases where part of the therapeutic input is just being there week after week and working over many years. But there are also cases that are being seen by well-meaning clinicians who are just doing more and more, but not actually achieving any effects. And I think we also have to be open to that possibility and talking with that as a community. different ways of reviewing the information. If you have more time to start thinking about the outcome measures, start creating stories with your supervisor and others, what does this mean? And then at 6 months review or a periodic review as your service works out, to have a more detailed assessment, to redo the RCADs and the SDQ, and also do a service experience questionnaire. This is one we use in the UK, about generally how people found the service, whether they would recommend it to others. So, to end, I'm very aware that in many ways you here are at a very exciting point of time and in advance of many of us, in terms of having an agreed way forward in terms of evidence-based guidance and practice. But what I would say is, that's fantastic, and I'm a complete supporter of it, and I run a unit named after it. But it seems to me that this can't work unless it's linked with outcome evaluation and consideration for young people of what their choices are within treatment. Because you can do the best evidence practice in the world. If it's not working for the young person in front of you, it's no good for them. You can have the best ideas about what the evidence tells you. If that's not what the young person wants, or it doesn't fit with their belief system or what they want in their lives, it's no good. There has to be somewhere a coming together here about, is this working, and if not, what will I do differently? What can I learn from the evidence, but what can I also contribute to the evidence going forward? And I'd like to leave you with one suggestion that I have found incredibly helpful in our work, particularly on the shared decision-making project where we've developed this. So this comes from models of quality improvement. It's the plan, do, study, act cycle. How many of you have heard of PDSA? Fine, about a sixth. So it's not a very complicated model. What it says is, if you want to try something new, first of all you plan it, then you do it, then you study it, and then you decide what you're going to do as a result of that new thing that you've done. The reason why I think this is so transformative in child mental health in the UK, and it may be different here, is that in the UK, we are very used to, as clinicians, thinking we can only do things as a group, that we all jointly agree this new way of doing things, or we all jointly agree a protocol, that we haven't got agency as individual clinicians to try something new with the next client we see. The quality improvement methodology says, be the change you want to see. Try it once. You can try it with your next client you see this week. Try one thing that you've got from this conference. Try something new and learn from it. So you might plan, I'm going to try using a questionnaire, a session-by-session monitoring, with a particular age group, with a particular gender child, and with a particular problem. So this is with a particular child. The child I'm going to see on Friday, I'm going to try this. I might introduce the measure in a particular way, see what happens. I'm then going to think about what that was like. It may be a disaster. It may be it doesn't work at all. It may be, therefore, I say, I'm never going to do this again. Or it may be I say, I'm going to try it with someone different. I'm going to refine the way I do it. But this is about trying to bring back feedback loops for our own thinking so that we're not so caught up in the enormity of what we're doing to think and learn. Thank you.